Okay, I guess we're live. Hello, welcome everybody. Good morning, good afternoon, and good evening. Thank you for joining us today. This is CDEP's sixth webinar in the conversation series, which we launched earlier this year to celebrate 10-year anniversary. My name is Erta Kalanji, and I'm a researcher at CDEP, and I will be moderating the webinar today. Today's theme will be on One Health surveillance in the context of the post-COVID era. And as usual, we are very thrilled to have a panel of experts today with us to discuss different aspects of this theme. So from the United States, we have Professor Amy Pruden from the Department of Civil and Environmental Engineering at Virginia Tech. We have from India, we have Professor Ramakrishnan from the National Center for Biological Sciences. And from South Africa, we have Microbial Research Unit at the University of KwaZulu-Natal. So following a discussion with the speakers, we'll have some time at the end of the session to address any of your questions. So please do enter them in the Q&A section in your Zoom app. And for those of you who are following live on Facebook, you can also enter questions under the video in the comment section. So we're ready to start our session, and we'll open today with a brief introduction from CDEP's director, Dr. Ramanan Lakshminarayan. So Ramanan, thank you, over to you.
Thank you, Erta, and it's a real pleasure to have you all back for the sixth webinar, and we promised 10 for our 10th year anniversary, and so there will be 4 more. So this particular webinar has a lot of reference to where CDEP is going next as the One Health Trust, as we discussed last time. And one of the things we're doing is investing in significantly in One Health surveillance, mostly focused in India, but looking to see how to move these ideas around the world. And One Health surveillance has been one of these concepts that has been around for a while, but no one is really quite sure what it means. So far, I think One Health surveillance is still, although we define it as helping to understand the drivers, reservoirs, and pathways for the emergence and spread of resistant pathogens, I think it's been stuck in a space where what I would call stage 1, which is we're tracking resistance and presumed drivers of resistance in different domains, whether it's wildlife or animals or humans. But we haven't really done a huge amount in terms of making the connections between them. We have done some, but the stage 1 is where we're really at, which is tracking resistance, which itself is a huge challenge because data on resistance is still not available, even in high-income countries, from, say, environmental samples at the scale that one would expect by the time, we've reached to this stage of the problem. I think the second stage is to correlate resistance in different One Health domains. Now, this is more challenging to do because these have to be ecological. Now, here we have evidence that, from sewage samples that you can mimic what is going on in the hospital's, resistome by tracking that in sewage samples. But here there's a lot of opportunity to being able to see what those correlation patterns really look like. I think the third stage is really to build evidence on the drivers of resistance, which is between the domains. So correlation then has to lead to causality. Now, this is even more challenging because we might have to do these through well-designed experiments or using natural experiments. And here, it's a range of questions which also relate to things like climate. How does climate relate to driving resistance, emergence of gram-negative infections, emergence of fungal pathogens? Again, work happening here, but still much less than one would like to see. And I think the last thing, which is really where we try to get to, is eventually the surveillance is all towards designing and testing One Health interventions. I mean, I'm personally interested in understanding what infection control in a One Health sense really means. How do we really actually prevent spillovers? We know that increased deforestation or any place where there's impingement of human activity on wildlife or with animals does create potential for spillover. But these are very broad brush kinds of recommendations. Are there more specific recommendations that we can use to prevent spillover with the fine-grainedness that we know and have for, say, infection control within healthcare facilities. I'm sure that's coming down the road, but we have to understand what that really would entail going further, because as COVID has demonstrated, and as we've always known, all health is really one health, and the separation between the domains in terms of understanding drivers has always been rather artificial. But fortunately, now we have more people who understand the importance of One Health, and I definitely see greater investment in One Health surveillance as we go down further. And it's incumbent on us as the community that's thinking about this to define what One Health surveillance really looks like. Obviously, we have a great set of speakers who know a lot about this subject, so I'll hand back to Urta to take you through the panel. Thank you.
Thank you, Ramanan. We are going to start with Professor Amy from Virginia Tech. And the first question that we'd like to explore is basically on some of the lessons that we consider as important from this period, which we can carry on in the immediate future. So this is when it comes to adopting a One Health perspective for surveillance of various diseases. So thank you, Amy. Over to you.
Well, thank you, Erta, and thank you, Ramanan, for the opportunity to be here. Certainly, I think we all know there are infinite lessons to be learned from the current COVID-19 pandemic, and just the devastation that we're witnessing in terms of loss of human life. I think we all know loved ones that have succumbed to COVID-19. Economic loss, the pain and suffering psychologically, socially, politically, the unrest, so clearly we want to avoid this kind of thing in the future. We've also seen the interconnectedness. It's been astonishing how quickly COVID-19 spread to every corner of the earth, Pacific Islands, everywhere. No place was spared. And I think that interconnectedness, though, also highlights the need to work together, that, not only the importance of public health and global health, but if we are going to prevent this kind of devastation in the future, we're going to need coordination. And I think One Health really illustrates that interconnectedness. So you've got people, animals, and the environment. And obviously with COVID-19, we had the zoonotic connection, and with bats and other animals are also susceptible to COVID. And we see in surveillance, as Ramanan talked about, we're kind of in stage one where, we monitor maybe food, and we have decent clinical surveillance in some parts of the world. But the environment part of One Health, I see, really needs some catching up. And with COVID-19, we saw how important environment is to transmission, right? It's spreading through the air, that's the environment. And there's a difference if you're indoors or outdoors, or if you're 6 feet apart. And I think we're also learning about humidity, temperature, things like climate for sure will play a role. And of course, disparities in terms of people that are more vulnerable to exposure because of where they live and what their job description entails. So we need One Health surveillance. We've seen that with COVID, and that's going to be true for any disease, certainly for antibiotic resistance, and that can help us to contain future pandemics, prevent them, mobilize resources. And with COVID, we've seen another environmental connection with surveillance. We've seen sewage surveillance as something that's really taking off as maybe an integrated target that can help us to get our minds and hands around future pandemics.
Thank you, Amy. Thank you very much for this very relevant opening remarks to today's discussion. So the next question is a little bit more specific. Are there any technologies or initiatives from this period that we can leverage to actually improve surveillance of the other silent pandemic? We are talking here about antibiotic resistance or antimicrobial resistance. Thank you.
Absolutely. And so with antimicrobial resistance, you know, it's a different beast than your typical pathogen, because with COVID-19, as complex as it is, we have, you know, one virus or variants of that virus, and we generally know what the genome is and we're trying to track it. But with antimicrobial resistance, you have numerous pathogens that can pick that up. With antibiotic resistance, we're specifically dealing with bacteria, numerous bacteria, you know, that can carry antibiotic resistance, and numerous genes. So there's thousands of antibiotic resistance genes that can be carried and shared among bacteria. And we also worry about new ones that can evolve. And these antibiotic resistance genes are what give bacteria the ability to fight antibiotics. And so what we're worried about is the general trend that when we need these life-saving drugs, that they're not going to work. The bacteria have evolved or acquired the ability to resist them. And so as I mentioned with COVID-19, the sewage surveillance is something that really got traction. And it was very encouraging to see, you know, there was early work out of the Netherlands, but spontaneously all over the world, these networks emerged and coordinated and shared data and all looking at excretion of the virus in feces and seeing when it shows up at the wastewater treatment plant. And we've seen that you get 1 or 2 weeks early warning. You can see in a community, okay, COVID's headed this way, let's mobilize resources, let's be prepared. And I think although antimicrobial resistance is much more complex, the sewage surveillance really has a great deal of potential to do the same thing for antibiotic resistance. So, you know, right now with food or clinical surveillance, it's challenging. We're doing isolate by isolate. You know, it's a lot of work to collect that data and coordinate it and compare it. But with sewage surveillance, yes, you can also do the isolates. You can look at E. coli or Enterococcus or Pseudomonas, whatever your target is, but you can also directly extract DNA. You can do shotgun metagenomic sequencing, and you can get a full profile of those thousands of antibiotic resistance genes that are present, some information into the bacteria, microbes that might be carrying them. And so, you know, it's much more economical and efficient. And so I think there's a great deal of potential there. And we built the infrastructure with the COVID sewage monitoring. I know in Virginia Tech campus, like many universities in the US, we started monitoring it in our university campus sewage, and we were able to devote our testing resources to where we thought there was infection. So similarly, with antimicrobial resistance, we could see in a community, okay, these are the antibiotic resistance genes circulating. Here's where we have a problem. We can integrate it with healthcare surveillance, and doctors could have an app and say, okay, here are the antibiotics that are most likely to work. They can also see other diseases, right? And see what's circulating and have an idea of how to optimize treatment of infection. So I'm hopeful at this moment that there's lessons learned and that there's technologies that are establishing, and that we really have a key opportunity at this moment in history to really be prepared for controlling future spread of disease, and especially antimicrobial resistance.
Thank you so much, Amy. I really hope that this infrastructure is used more for antibiotic resistance in the coming years, and hopefully close the gap on the knowledge we have on the AMR burden across the world. So thank you. And this is it's actually a good transition to our next question, which is on molecular surveillance. And it's directed towards Professor Uma from India. So the question that the question we had is on the current status of the molecular cross-species surveillance, and what does it promise for pandemic preparedness in the future?
I think that's it's a important question, and I think that as Ramanan said in the beginning, going towards understanding the drivers is something which hopefully we can move towards post-pandemic. And the thing we have on our side, also as Amy brought up, is, the genomic technologies available in the last 10 or so years have really exploded. And in some sense, the pandemic has forced many countries and labs across the world to equip themselves with the ability to sequence, COVID-2 genomes, which basically allows them to do, other kinds of surveillance. And the metagenomic approaches that Amy brought up potentially, can be used in the context that you were suggesting, where we try to look across species to see basically what is there, what is common, what do we know about, what seems. So when you do something like metagenomics, you just sequence whatever is there. And so some of it may be things you know about, and some of it may be things you don't know about, and things which are shared could be candidates for spillover, and so on. So I think that a lot of it will have to be very exploratory in the beginning, but it will require a lot of collaboration, I think, because these data on their own don't mean anything. If I just do metagenomics from a rectal swab of a bat, I have to be able to compare it to such data from bats from other parts of Asia. And that's when it becomes much more meaningful to sort out pattern. Okay, this is commonly occurring coronavirus across bats across Asia or something like that, versus something which is different or new. So I think with cross-species approaches, a lot of the approaches exist. They are relatively easy to actually implement, and not very easy, but the equipment or lab infrastructure required is not very, very out of reach of most labs in the world, many labs in the world, not most. And so I think, however, the interpretation of the results and what they mean is something which I think maybe we all need to work more on together to come up with, some kind of common frameworks and ways to share data and ways to make suggestions based on the data beyond just academic research.
Thank you so much, Uma, for pointing out that data collection is only one part of the answer, and analysis it's what's going to make it bring it into context. So when it comes to these technologies that you just mentioned, specifically the genomic surveillance technologies, what do you think are the challenges with implementing them in low and middle income countries or low resource settings?
Yeah, I think basically, one of the big challenges is reagents. I mean, it sounds almost silly, but basically, even having been part of COVID sequencing efforts, for variants, I mean, the day-to-day, it just takes very long to get these reagents. And that's not just true about COVID sequencing. I mean, the currency of this work, which is the reagents, is the same in, say, my lab research, whether we're looking at, endangered species or and conservation projects, or we're looking at, sewage surveillance, or we're working on, unknown viruses in bats. and unknown bacterial pathogens in rodents. The currency of these experiments are these reagents, often marketed by single companies, very good companies, excellent products, but for being in some countries, the import and all kinds of restrictions like that, it just takes very long to get them, and the timelines are like months, right? So if I place an order today, if I was in the US, I might get it in a week or so. But if I'm in India, it takes 3 months. And this is specifically true, even more true for non-standard things. So for example, there are now various new, companies which are using new capture-based approaches, where you try and specifically pull out, say, respiratory viruses or something like that. And these companies are very innovative. They're doing some nice things, but for low resource settings, to try something different is also very hard. So getting okay, this is standard stuff, and getting the constant flow of standard stuff. If you need 10 things, you have 8, but you don't have the 9th and 10th. And so just that, the inventory flow is something which is pretty challenging. And I think that the capacity for analysis, synthesis, and kind of deeper kind of collaboration and analysis is something which we haven't really thought about sharing so much before. I think this pandemic has really thrown open this need to share data. I mean, like never before. I mean, one did it, but it was almost like whatever is required kind of thing, when it's required. But the first impulse is to not share, but how do we change that ethos to first share and like let everyone throw their ideas in? What does this mean? Can we work together and maybe use this new virtual world, like, which of course it was always there, but we didn't probably leverage it as much, to really, ramp up our ability to understand, because there's a lot of patterns which will emerge. But what does that mean? What are the drivers in terms of process and, things like that? I think it'll be really nice to be able to, just like jump that learning curve, not go really slowly, but actually jump up higher. I don't know whether that makes sense.
Yeah, it does. It does. Thank you so much for sharing your, I guess this is very much based on the experience that you have with your work in India. So thank you very much for sharing this with us. I will now move on to Professor Sabiha Essack from the Antimicrobial Research Unit at the University of KwaZulu-Natal. And the question that I have is that on collaboration, basically, a little bit moving on from what you were just talking about, Uma. So One Health surveillance requires multisector and interdisciplinary collaboration, but this needs to happen at the national and global level for it to actually make sense. So what is the progress so far with achieving this, and what do you consider as challenges that we need to overcome?
So thank you, Arta, for that question. But let me start by congratulating CDEP for a decade of seminal work in antimicrobial resistance. Happy 10th anniversary. I think that the teacher in me wants to start with the definition. And I want to begin answering the question by reminding us all of the definition of One Health that was updated by the One Health Commission in 2019. And the Commission defines One Health as a collaborative, multisectoral, and transdisciplinary approach, working at local, regional, national, and global levels to achieve optimal health and well-being outcomes, recognizing the interconnections between people, animals, plants, and their shared environment. And Ramanan spoke about the interconnections, and I want to emphasize the word interconnections here. So taking a One Health approach to mitigating AMR is based on the prevalence and the transmission of AMR within and between humans, animals, and the environment. It is premised on the fluidity and mobilization of drug-resistant bacteria, microorganisms, antimicrobial resistance genes, and their mobile genetic elements carrying these genes within and across the One Health triad. So going back to the definition, the One Health approach focuses on the interfaces and the AMR risks to and the AMR risks by or from each of the human, animal, and environmental components. So I'm going to stop from my teaching role there and then speak to the challenges. So I agree that we are in stage one. I contend that the current global and national surveillance effort have not taken a true One Health approach. And I say that for three reasons. Firstly, surveillance is still really undertaken in silos with minimal integration and triangulation of AMR and AMU trends, antimicrobial use trends. Even in countries with well-established surveillance systems in humans and food animals, the trends are reported separately, and there's minimal analysis at the interfaces. If we look at the global level, the quadripartite One Health Alliance of the WHO, FAO, OIE, and the United Nations Environmental Programme have really developed sector-specific AMR surveillance guidelines and data sharing platforms. So that's the first aspect. There's AMR surveillance is undertaken in silos with minimal integration. Secondly, the integration and triangulation are confounded by the fact that we investigate pathogens in humans, but common cells in food animals. If we include occupationally exposed workers, we do see aspects of zoonotic transmission, but not necessarily zoonotic disease. And here again, the transmission pathways are not really elucidated. And thirdly, and most importantly, we have not answered the so what question. Several genomic studies have shown the prevalence of similar bacterial species or strains or sequence types, similar resistance genes, and similar mobile genetic elements in two or more compartments of the One Health triad. But we are yet to unequivocally establish transmission dynamics and the risks associated with the mere prevalence of AMR in the interfaces. In terms of the progress, I want to speak a little bit about the WHO Tricycle project, which is an example of how to conduct integrated One Health surveillance, albeit with limitations. Many of you will know that the Tricycle project focuses on a single indicator organism, ESBL producing E. coli, and it uses that indicator for integrated multisectoral surveillance. The protocol includes standard methodologies for surveillance in humans, the food chain, and the environment, and taking cognizance of low resource settings. There is, however, an absence of guidance on integrated analysis of the results, and we again see sector silos and gaps related to interface analysis, transmission dynamics, and the so what question that links transmission dynamics to risk. So in a nutshell, there is a need for a standardized One Health surveillance protocol. The protocol should have a minimal sampling framework, powered sample size, sample sources, sample frequency, standard operating procedures for quality assured sampling and laboratory investigations, both culture dependent and culture independent, but most importantly, and I can't emphasize this more, integrated and triangulated analytics. Thank you, Etta.
Thank you, Sabiha. Thank you very much. Our last question for today, which is also one of the reasons why we're having this webinar, is how can we actually improve awareness and knowledge on One Health and One Health surveillance?
So let me start by saying that knowledge and awareness of AMR as the quintessential One Health issue, as it is commonly known, is really critical for investment in One Health surveillance systems by policymakers, and this is the top-down approach, as well as for surveillance-informed decision-making by human, animal, and environmental health practitioners, and this is bottom-up. For this, we need evidence on the clinical, food safety, and economic impacts of AMR, and those are just three aspects that I can think about, but there's several more. And this evidence is generated from, you guessed it, surveillance. So robust, representative, quality assured One Health surveillance systems to understand the causes as well as the consequences of AMR at the interfaces. Such surveillance is essential to inform evidence-based interventions at policy as well as practice levels. And herein lies the conundrum. We need surveillance to make an investment case for surveillance. So we need integrated and triangulated AMR surveillance data to make an economic case for investment in the One Health surveillance of AMR. We also need to improve mortality statistics. Death registers seldom record drug-resistant infections as the cause of death, and loss in food animal productivity is seldom attributed to drug-resistant infections. Other speakers have already highlighted the fact that conventional laboratory-based surveillance is expensive, it is invasive, and it's biased to hospitals and intensive food production systems in urban areas. We know that the AMR burden is not quantified, especially in low and middle income countries, where surveillance systems may not be well developed or well resourced, and where multisectoral collaboration is still in its infancy. We also know that AMR surveillance, certainly in my country, was deprioritized as laboratories were dedicated to COVID testing and tracing. So let's look at the proxies, and the common thread in all of our presentations is the Global Sewage Monitoring Project. Amy and Uma have mentioned that this project takes a metagenomic approach and quantifies the abundance of and diversity of antimicrobial resistance genes in sewage. And this project has extended to more than 100 countries. They've also mentioned that it was used to monitor COVID-19 at population level. And what this monitoring project has shown is that there are systematic differences in antibiotic resistance gene profiles between countries and continents, with low and middle income countries showing higher sewage levels of resistance genes. When it was expanded to a culture-based approach, there was some correlation between the E. coli from sewage to urinary E. coli isolates from primary healthcare level. While such population data is not likely to inform treatment guidelines, it does have the potential to monitor AMR trends and serve as an early warning system for emerging or escalating resistance to inform interventions. Expanding the Global Sewage Project to include AMR surveillance in food animals will provide proof of concept for a cost-effective, non-invasive, representative One Health surveillance system. And this may be adequate to make an investment case for more sophisticated One Health surveillance. And finally, I would be remiss if I didn't leverage COVID in this conversation. We should really leverage COVID-19 pandemic to reinstate AMR as a priority on the global public health agenda. We should build on the existing knowledge and awareness on pandemics and present AMR as the silent pandemic that is adversely affecting humans, animals, plants, the environments, and their various interfaces and ecologies. That AMR is a One Health pandemic, and its impact is so much more far-reaching than COVID-19. AMR adversely affects the food we eat, the water we drink, healthcare and food safety and food security as we know it. So investing in One Health surveillance of AMR is really not negotiable. Thank you, Essa.
Thank you very much, Sabiha. And at this point, we actually are ready to answer some of the questions that our audience has sent. And this is the first one is directed to all of the panelists. So I'm just going to read it to all of you. So do you think that global surveillance in AMR can be harnessed the same way as COVID-19? Data was collected and shared from different parts of the world in COVID-19's case, but can this be done for AMR since AMR surveillance tends to occur in pockets or silos, almost disjointed?
Well, I can say, I guess the short answer is yes, but the long answer is it's complicated. And I think Sabiha did a really nice job of outlining some of the specifics that need to be thought through. But one aspect with COVID that I think is really a game changer are the public facing dashboards. I think in the past, there's been this hesitancy, like you want to communicate to the public, you want them to be informed about public health, but you don't want to scare people. And the art of communication is very important to consider, but COVID was all out there. People knew it was happening. They had loved ones that were sick. And so now you open the newspaper and every day you see the epi curve, you see local, national, international. And I think this can be a game changer where, I think people now are awakened that the importance of public health, that it's all interconnected, and they're more used to data. I think just we're in the age of information. And so our aim needs to be to provide good quality data. And I think take advantage of the success of these public facing dashboards, and people can see the trends for themselves. And I think that can help engage people, but it can also help to, for the public health and the authorities to address the spread of antimicrobial resistance.
If I may, Etta, I think that leveraging the pandemic, as I spoke about earlier, is one of the aspects. We hear about the face of COVID because it's so out there and in your face, but AMR is really not understood because it, as I mentioned, that it is really, we don't really know whether the person died because of a resistant infection or there was loss of animals because of a resistant infection, and maybe optimizing those kinds of databases would assist. I know that there are a number of initiatives in different regions where the Fleming Fund, for example, is looking at data sharing platforms and trying to ensure that whatever data is generated from public funds, if you like, is going to be made available and accessible. But remember that this also requires political will. And there's also the ramifications on the economic and other fronts if scary AMR data is suddenly made publicly available, that this country is really has really high levels of resistance. So it has an economic impact. So there has to be some sort of circumspectness to make sure, first of all, that the data is accurate and representative, and that it's presented in a way that is not disadvantageous to economic growth and development, as well as other aspects within the country. So I think it has to be packaged and messaged in a way such that all the people concerned take the relevant precautions to prevent, contain, and mitigate, and not have an adverse effect on other aspects. Over.
Thank you. We have another question. Thank you so much to both of you. We have another question, and it's about funding. So there's now more funding for stopping future pandemics, including stop spillovers in the US. How can we leverage this for AMR One Health surveillance? And what would your top 3 funding priorities be? I guess it's an open question.
I can jump in actually just with a comment on the last question also. I think that I think communication is something which is really key as well. And, Amy's mentioning the dashboards. I think it's really important, but I also think that in countries like India, where there's oftentimes, language barriers, knowledge barriers, all kinds of barriers. I don't know the answer, but somehow ways to be to make sure that there is communication, not just to a certain part of society, but more broadly, is something which we have to really think about. And there, Sabiha's point of will really comes in, because there should be a will to communicate to everyone, and the will to disseminate knowledge. I think that's really important. In terms of funding priorities, I think that actually this may maybe sound silly, but ways to actually encourage collaboration, and not just data generation, but translation. So first of all, multisectorial, but also translation of that data and interaction of those, the scientists and the data with policymakers, and impacts on the ground. Because a lot of, if you look at, there's a lot of gaps between, scientists and people who are actually public health workers who are actually doing things on the ground and changing things on the ground. Scientists have very different goals, or so somehow encouraging that I think would be the biggest, could be the big one, very high priority area. And also maybe a collection of case studies and ways for such groups of people to work together, so to leverage from the experiences they have had with antimicrobial resistance. I think also just communication itself is something which is really important in the context of all of this, not just research and data and case studies and examples, is actually talking about this and interfacing with public to really, I think, communicate what these things mean. These very complex interactions, right? So how do you actually present complex interactions without either reducing the complexity or saying, oh, it's so complex, we don't understand anything. Thanks.
Thank you. And I think we have a question here that sort of brings another important point, which is related to data sharing and collaboration. So what about data standardization? Like, how could any of you comment on what needs to be done or what is available out there to kind of, allow to bring all this data together?
That was exactly going to be my point with the previous question on, it's great to see interest in investing money in research, but I think standardization is going to be essential here. And I think for that to happen, we'll need some sort of involvement like World Health Organization, quadripartite, because, if you leave it just up to researchers, they play a very important role in innovation and new ideas and let's try this, but we need standardization, especially with metagenomics, for example. How deep do we sequence, what platform, what are the algorithms for identifying antibiotic resistance genes or emerging ones? A lot of things to think about. And with the culture, I think the WHO tricycle protocol has really been an exemplar of that kind of coordination that we need. And it's across the One Health spectrum, picking a target like E. coli that's relevant across the One Health spectrum and coordinating and testing it in different types of matrices that food, environment, and clinically relevant. But that's just the tip of the iceberg of what needs to be done. So I'd really like to see at an international body level, that coordinated surveillance. And I think that can also help with some of the issues we've talked about. Like, we want to avoid finger pointing, right? Like with surveillance, flags will rise and, there can be that tendency to finger point. But I think we need to abandon that mindset and take on one. We're all in this together, right? Like with COVID, it spread so rapidly, we all played a role. And so, we need to play as a team here.
Just to add to that, Etta, I think that standard operating procedures, guidelines that can be adapted to any kind of country context. And I really want to push the low and middle income country context and the resource constraints that we have. So that's really becoming really, really important to be able to have quality assurance, but also that when you're comparing the data within regions or even globally, you are really comparing like with like, and there hasn't been any technical issues that have falsely elevated or decreased levels, etc. So the technical component of surveillance is really important. Over.
So another question that has to do again with funding. Do we know who might find this work on correlation, identification of drivers and intervention design in each of your countries where you work?
So I think most countries have developed national action plans, and key to any national action plan is a multisectoral coordinating committee. And this coordinating committee has representation from human health, animal health, and environmental affairs, and various other departments and divisions within each of the big ministries. So this is meant to be at a level, and we almost require the people that are from the ministries to take a step back and maybe compromise a little bit in terms of their sector mandates to have and mobilize around the greater good of containing antimicrobial resistance. So most countries will have this multisectoral coordination group, and they would be the best placed to set up One Health surveillance within a country. That's where I would place it. And yes, in most countries, it's generally the Ministry of Health, sometimes the Ministry of Agriculture that takes the lead. And ministers are all on the same level, right? So you need to almost have one level up above the ministries and have this transdisciplinary, sectoral approach to it, such that everybody contributes and works towards the common goal of AMR containment. And I think that people need to see that the sector does not exist in a silo, and that what happens in human health affects animal health and vice versa, and both affect the environmental health. And if we have this understanding of the interdependence on each other and how AMR in one sector really affects every other sector, I think there'll be more will to work together towards the common goal. Thank you.
I think related to that, we see that there are some common goals across sectors. So I agree, we have to get out of our silos. One example would be, the strategic development goals. So many of those, if we address those, will also be addressing antimicrobial resistance. So an obvious one is poverty, right? So we see hotspots for spread of antimicrobial resistance also happen to be in areas of poverty, and that socioeconomics might be the biggest driver according to some studies. So that's just one example. And, funding, we need the political will. One example is the JPIMR initiative that several countries have joined, and they chip in. And so I hope the United States will be one of those countries, and there's others that aren't yet on the list. So I think, there's reason to be hopeful here, and we're taking baby steps, but we need to take much bigger steps.
I guess maybe I'll present a slightly more pessimistic. I think that, there's absolutely no doubt that there's a need to break out of these silos. I hope that that's possible. My experience has suggested that it's quite difficult. I hope that will change.
So we have a couple of more questions that we can cover quickly before we close our session for today. The first one is, there's two questions which I'll just combine them into one, and that's on the role of social media that in conveying the message on One Health surveillance. Are there any cases where this has been done?
Not that I'm personally aware of, Urta. I think social media has been used well, and also not so well when it came to COVID-19, and any kind of media that is used to send the message out. So AMR is a whole of society problem, and it requires everybody to play a role, from civil society through to the policymakers and the healthcare professionals, etc. And I think that the messaging, as Uma mentioned, the messaging becomes really important, because we need to make sure that we send the same consistent message to different sectors of the population. And it really has to be repurposed so that it is aligned with the health literacy levels in different countries and in different populations. So it is really important to make it understandable without fear mongering, but really send the message through to say, it's your responsibility and this is how you can prevent it. This is how you can ensure that antimicrobials are going to be available for your children and your grandchildren. I don't think using huge numbers like 10 billion, 28 million people in poverty, 10 million people will fall. That doesn't bring the message home. Those are really good statistics, and they're really good for economists and the global political leaders. But really, if we need to make sure that everybody's going to play their role, we need to just repurpose messages such that it is applicable and people are going to buy in and implement them.
Thank you very much, because that was the last question I was going to ask was, what is the message that should go through to the layman on the importance of the silent pandemic in the post-COVID era? So how can we communicate this to people like at the community level?
Maybe I can start by saying, making the examples really real to them, something that you can relate to within your own individual and small circle into that context. It really thinks about, we've used comics and movies and podcasts and art, and we really need to think of using all of these kinds of media to relate to the very people that we need to take all of the interventions to going forward. So it's just being creative and innovative, but saying the same thing in different ways so that it aligns to the health literacy and the age group or understanding of the people that we're trying to reach. Okay.
I think that also, I mean, this is just my naive impression, but I think that in countries like India, where 70% of the population is below 35 or 40, there needs to be, I think, especially in terms of things like communication, we really need to also think of how to communicate, like you mentioned, Sabiha, to different age groups. And I don't feel like we are doing that effectively at all. And I think that the other methods you mentioned, the other media tools, some of which at least someone like me who's on the other side doesn't even know the names of, I think will be really important to first get people aware and really thinking about this. I think that's the first step, because I think people aren't even cognizant of it so much, right? So the first step is to build awareness, and then bring in, if you do this, this may happen. If you do this, that may happen. And this is why that is important. But first, just awareness, I think is maybe the most important thing.
Right. I think, similar with the COVID-19 pandemic, people had to be aware, right? If they were awake and living and breathing, they were aware. And with antimicrobial resistance, I think people don't realize how much we depend on antibiotics and antimicrobials, and that the standard of living that we do have and that life expectancy is longer than it was in the past, and that you don't have to worry as much about minor infections is because of antibiotics, and that that can easily go away, and it is going away for many types of infections and contexts. So I think building appreciation for the value of antibiotics as a precious resource, and understanding that it's one that we have to be good stewards of, and that, so then the next step, as Uma said, is then, okay, what do we do about it? And we all play a role at many levels, from basic hygiene, like water, sanitation, hygiene is a big aspect of stemming the spread of antimicrobial resistance, to prudent use in agriculture, choosing products that don't require the use of antimicrobials, antibiotics, and educating healthcare folks too, because they're not always as aware as you would think they would, and so that doctors and clinicians don't rush to use antibiotics when they're not necessarily necessary, and use the correct ones for for the right situation.
Thank you very much, Amy, Uma, and Sabiha for today. Thank you for joining us on this very important discussion. I think it's time to close our session for today. Thank you to everybody who joined and interacted with us with our questions. The recording of this webinar will be on our website, on CDEP's website, so you can access it there. You might also get an email from us with a recording. And please stay tuned for the next 4 webinars in our series that are coming up soon on antimicrobial resistance and COVID-19. So thank you and have a great rest of the day for everybody who still is early in their day. Take care.
Thanks very much for the invitation and nice to
Yes.
meet you all. Thank you. Bye.
Thank you so much.
Bye. Thank you.
Bye.